No, that is what makes it comes out. Not cheap. That's my dream. That's a beautiful drawing.
Hi.
Hello.
Hi, John Reynolds here. I'm not sure why I'm coming. I'm definitely not Claire Donahue.
Oh, yeah. Sorry, Prof. Yeah.
I don't know how this works.
That confused me a little bit. Sorry, Prof. Yeah.
Confused me too.
So anyways, I've made you the host anyways, so that you'll be able to share your screen, Prof. And
Okay.
once Claire joins, then I can make her the host and you could be the co-host if that's all right.
That's fine. Yeah, whatever.
No, I say Elizabeth is there as well. Hi, Elizabeth. So I think you're on mute.
Hi, it's nice
Hello.
to meet you. I'm Lizzie.
Hi, Lizzie. I'm Bridge. Nice to meet you.
Nice to meet you. Where are you located in the world? I see a bright horizon behind you.
Oh, I know that. I think it's my son. He keeps on changing these things. So I am in Derby, very much at home as of now. And you know what? I don't even know how to change my background.
Very good. No, the background, my computer is actually too slow to support a Zoom background. If I want a Zoom background, I have to go on my laptop.
All right.
Otherwise it's the bookcase.
Unless I try and...
So I think the Irish are strong at the meeting this evening, John.
Yeah. Well, we're not appearing at the Euros, so we have to show our strength somewhere.
Do we have competition? No. Oh, okay, I didn't realize. Is there a match on this evening?
No, we don't have any competition, but we're just not there.
No, I know that. Yeah, no, I know that, but I don't know if there's another match on.
No, tomorrow, no, Friday and Saturday are the next round of games.
As you can see, I'm an avid fan.
Yeah, absolutely. Yes. all those football books in the background there, I see them.
Yeah. How many do you expect at the meeting?
So we have over 700 registered. But these are, what happens now is we have one registration for all TUGS Lounge meetings. So this is from when we started. So generally we have a turn up of about 100 to 150.
That's amazing.
Yeah, it's quite a good, there you go. I think Claire's just joined us. So we've got Claire.
Hi, everybody.
Good. Hi, Claire.
Hi. Thanks for coming, everybody.
So Claire, I'll make you the host. I made John the host a minute ago, so then you can make the other Claire.
Claire, how are you? Nice to meet you. I'm Claire.
So John, sorry, can you make the right Claire the host now, or you make me the host and then I can make her the host?
I have no idea how to do that.
If you click on either my picture, so TUGS or Claire's picture, you'll see 3 dots on the right hand of the picture.
On Claire's picture, okay. Yeah. Got it.
And then you can make her the host.
Perfect.
Yeah.
Yeah.
Yeah, excellent. Yeah.
Okay. Will I be able to share the screen then? If Claire enables it, is that right?
Yeah, Claire, can you make John the co-host?
Yeah. Okay. Yeah. Good.
Sorry, I was muted there. So I've renamed you and your co-host. Lizzie, I was just going to make you co-host as well. We haven't actually met in real life, but thank you very much for joining the meeting.
No worries. Nice to meet you too. Thanks for inviting me. Cheers, Shiraz.
Hi, Lizzie. Hi.
Hi, Shiraz. Thanks for coming.
Yeah. Hi, Claire as well. Hi, sorry. I just finished.
Hi, Shiraz.
Hi. Oh, hi.
So I'm just furiously trying to find the brochure for the course that the group are running on Saturday somewhere, so I can advertise it at the end. So I'll keep clicking.
Oh yeah, that'll be good. Do you want me to find it, Claire?
No, I have it somewhere.
It? Yeah? Okay.
Buried in my email. I've had so many emails about it. So I just have to find it where it is. And Brijesh, just the next one of these meetings, just for the end, is that what's the theme for that, or have you decided yet?
For the rest of the meetings this year?
Yeah, I suppose the next one will that be in August?
Yes, the August one. Yeah, so August one is going to be on anti-reflux surgery. So we'll try and do some discussion on decision making. And then we have one on bariatric in September. So we could plan maybe another one on esophageal cancer in November, if you would prefer.
Yeah, cross that bridge.
That'll be good. Yes, I've made plans for the rest of the year, and then we'll see. I think we're getting good at attendance, and so far the feedback has been good as well. So I think hopefully we'll keep going. John, did you want to try to share your screen? Do you want to just do it?
Sure. Yeah.
Just on one occasion, we had really bad technical problems. So yeah, I think that's working all right. Yes.
Okay.
Yeah, excellent. Yeah.
How many meetings have you had so far?
So this is our fifth one, I think. Yeah, fifth one. Yeah, so this is the first one on esophageal cancer. The first one we did was on academic surgery. So how to, start on the academic journey, how to get involved in academics. Then we did one on safe cholecystectomy. Mark was talking on that one. And we had some really good speakers then. And then we have done one on bariatric complications. So yeah, I think a variety of things, and I think that keeps the interest. So I'm just keeping it. Sorry, John.
No, that's great. Go ahead.
Yeah, I was just saying, Shiraz, are you going to keep an eye on the chat function? Is that all right between you?
Yeah, absolutely.
Yeah.
No
okay,
problem.
that's fine. Yeah. I'm just saying, I think Mark has just sent me something.
I found the last one on bariatric complications really interesting. There were some kind of rare video complications which I hadn't seen in practice. So
yes,
I'm sure at some point they'll appear.
Yeah, well, they're scary when they happen. I can tell you it's. I've only been involved in one, and you usually get a colleague involved in those ones. Yeah.
So Claire, did you want to see the presentations to 10 or 15 minutes, was it?
Whichever. I think, 10 to 15. The timing is kind of, not that important. Thought it would be good to just go with 2 presentations rather than kind of ending with like lots of people to talk and then running out of time and kind of rushing towards the end, which sometimes happens. So
always the way.
Yeah. I think short and sweet, maybe.
So Claire, do you wish to start? I think we're just gone at 8 o'clock. You can.
Yeah.
I think we can start, and what we see is people keep on joining in. You know, they can join anytime. So.
Sure.
Right. Yeah. Okay.
So welcome everybody. Thank you very much for joining us for this TUGS meeting. It's going to focus on the kind of modern management of esophageal adenocarcinoma. I'm really delighted to welcome the speakers this evening and my co-moderator. I find every time I talk to these people or have listened to talks from them about esophageal cancer, I learn something new, that you will all learn something that you'll bring to your own practice this evening. So I'm going to kick off the introductions, and I'll introduce myself, and then I'll ask the other members of the panel to give a brief introduction to themselves. So my name is Claire Donoghue. I'm a consultant surgeon in Trinity St James's Cancer Institute in St James's Hospital in Dublin. I work alongside Professor John Reynolds, who will be speaking this evening, with whom I also did a PhD during my surgical training. And I've worked, I did most of my training in Ireland, but I did 2 international fellowships as well. So I worked with the Northern Oesophageal Gastric Unit in Newcastle upon Tyne. And then I did another year of minimally invasive surgery with Oregon Health and Sciences University in Portland in Oregon, who run quite a high volume esophageal cancer center and program there. So that's me. So I might hand you over then to Professor John Reynolds to introduce himself.
Hi, Claire, it's a pleasure. So I'm John Reynolds. I'm chair of surgery in Trinity College Dublin, and fortunate enough to be a colleague of Claire in the Trinity St James's Cancer Institute in the Upper GI program there. So yeah, thank you very much for the invitation.
Thanks for joining us. And then next is Elizabeth Smith.
Thank you. It's nice to meet you all. I'm Lizzie Smith. I'm a medical oncologist based in Cambridge in the UK. As you can probably tell by my accent, the Irish are out in force this evening. So I originally trained in Dublin and then left there about 12 years ago to spend 2 years in America, and I've been in the UK for the past couple of years. And I focus mostly on upper GI cancers. So thanks for inviting me.
Thanks for joining us too. And then my co-moderator is Shiraz Marker.
Hi, I'm Shiraz Marker. I don't have a great Irish accent, so I won't try, but thank you very much for
Honorary Irishman, definitely.
Yeah, exactly. Thank you very much for the invitation, Claire. So I'm currently Senior Upper GI Fellow in Oxford, and previously was a clinical lecturer with George Hannery in Imperial College, who did most of my upper GI research with. So thank you very much for the invitation. I'm really looking forward to this, actually.
Great. Thank you. Thanks everybody for joining. So I think we're going to kick off. We have 2 talks and then we have kind of a mini case discussion to talk through, I suppose, maybe the implications of some of the research we might hear about. So I'll ask Professor Reynolds to start, if that's okay. So he's going to share the results of the recently completed Neo-AEGIS study that was recently presented at ASCO.
Yeah, thanks very much, Claire, and hello everybody again. So it's my pleasure really just to present to you preliminary results of the Neo-AEGIS trial that we presented at ASCO just a few weeks ago. The genesis of the trial was the cross randomized clinical trial, which was published in 2012, which showed a very substantial difference for multimodal therapy compared with surgery alone for squamous cell cancer, and also a significant, although just borderline significant, improvement for adenocarcinoma. So the question at the time, and really since arising from that, was should that cross regimen be the standard of care for adenocarcinoma of the esophagus and junction, is what we see in certainly about 75% of our patients here and in the UK, or what about those trials that went before it that showed that preoperative or perioperative chemotherapy, where does that leave them? Does the cross trial require validation, if you like, in a randomized trial compared with optimum pre or perioperative chemotherapy? And of course it did. And the opportunity was to design a trial at that time to compare them both. And this was the original trial design of Neo-AEGIS. It was just esophageal and junctional adenocarcinoma. Cross was the standard, so arm B. And RMA was chosen. We had a few options, but we chose a modified version of the MAGIC regimen based on RAIL-2 proof of equivalence of oxaliplatin with cisplatin and capecitabine with fluorouracil, which was really modified MAGIC regimen versus RMA, the experimental arm, versus arm B, which is CROSS, and it was powered on CROSS being 10% superior to the experimental arm. The primary endpoint was overall survival, and there was lots of interesting secondary endpoints like disease-free survival, recurrence-free survival, time to failure, tumor regression grade, and other proxies, if you like, of pathological response, toxicity, and operative complications. We felt was going to be a very important secondary endpoint. What happened then, as the trial was going on in 2017, the FLOT trial, FLOT4 trial was presented at ASCO and subsequently published in 2019. So that really demanded that we consider a protocol amendment, which we made. And the protocol amendment was to allow an oncologist for a patient randomized to RMA to have the option of either the MAGIC regimen or the FLOT regimen. So that was introduced then, and the trial design in terms of the power calculation was changed to a non-inferiority based partly on the introduction of the FLOT regimen and partly on the first interim or futility analysis at that time with 71 deaths, which showed absolute equivalence of arm A and arm B. So it became a non-inferiority design. The key elements of the trial, just adenocarcinoma, as I mentioned, very similar criteria to CROSS in terms of tumor length and so on. And then mainly, I think partly because the surgeon was designing it, there was a few other elements that we were particularly interested in. All the patients had to be uniformly staged with CT PET to have optimum staging ab initio. There was radiotherapy quality insurance, which we felt was very important in trial design because there was a question, there remains a question as to whether radiation therapy can predispose towards worse operative complications, particularly respiratory complications. So QA was very important, and we'll come to that again. And then operative complications were strictly defined as per the esophageal complications consensus group led by Don Lowe, which was just emerging at that time with an established, agreed lexicon, if you like, of defined complications. This was hugely different to what went before in terms of being able to within a randomized trial to document whether there was differences between the two arms. Severity of complications was as per the standard Clavia-Dindo score. So radiation quality assurance was very important. Tom Crosby had a huge role in this in QA. He combined all the UK sites as per previous trials like SCOPE and NeoScope. In Ireland, Brian O'Neill and he oversaw exactly the same protocol at QA for radiation in Ireland and in the continental European sites. And really, every center had to submit a process document beforehand. Every center had to go through a few benchmark cases of a lower esophageal and a junctional case that satisfied the leads. And when the first few cases were done on trial, they were assessed again, validated and assessed by the leads, and at random then 10% of cases on the cross arm, on the control arm, through treatment were looked at by the QA, the respective QA group. So variations and problems in terms of, you know, the planning treatment volume, the PTV, or in terms of dose volume histograms for organs at risk and were monitored, and if there was any problems, feedback directly to the relevant center. The standardized definitions for complications was probably well known to all esophageal surgeons who are listening in here, but again, I think this is a very important and unique to date element within a randomized trial in esophageal cancer surgery. So it's great to use that with permission from Don Lowe and that group. So this is how we got on. Started in Ireland through to before the UK for various reasons, before the UK sites could get on with support from the NIHR It really didn't get going until the start of 2015 in the UK, followed by Rikshospitalet in Copenhagen, and very laterally then by Lille, and even more laterally just a month or two towards the end of 2020 by the Karolinska in Sweden. And 377 patients had been recruited across 25 sites and five countries. And the data I'm going to show you is the data from the analysis of that, which informed the second interim or futility analysis at the end of December 2020 and what was presented at ASCO. So briefly, this is the demographics: Arm A, experimental, perioperative chemo; Arm B, control, cross-arm. Same age, same sex ratio. Just 27 patients in the Arm A were FLOT, the rest were MAGIC. Vast majority of patients, over 80%, were locally advanced, CT3. Majority of patients had predicted node-positive disease, 56 and 60.3%. In terms of the surgical approach, the vast majority of patients had a non-blocked transthoracic esophagectomy. 18% and 12% had completely minimally invasive esophagectomies, and transhiatal esophagectomies and extended gastrectomies were very rare. In terms of toxicity, as you would expect with chemotherapy, neutropenia was significantly higher, diarrhea was significantly higher, vomiting was significantly higher. Toxic deaths were no difference. In terms of tolerance of the treatment, so predominantly MAGIC, but with some FLOT, 92% tolerated all the preoperative prescribed regimen. For all the cycles, 6 or 8 cycles of chemotherapy, 42% tolerated it, and 62.4% had greater than one or greater adjuvant treatment regimen. So how about the markers of response that we look at when we look at the resection of the specimens? Well, the pathological node negative percentages were greater in the cross arm. The OR0, the resection margin, negative resection margin, was significantly greater in the cross arm. PCR rate was 16% versus 5%. The major pathological response rate, which is a combination of tumor regression grade 1 or tumor regression grade 2. So regression grade 1 is no tumor regression grade 2 is just less than 10% viable residual cancer cells, was markedly more in the cross arm than in the chemotherapy arm. But they were highly significant differences in terms of those parameters in favor of the multimodal cross regimen. How about operative complications? And again, this was something I had a huge interest in, and I'm very interested to see what would happen. And postoperative mortality was no different. 3 deaths in the chemo arm, 5 deaths in the cross arm. Nasomonic leaks, no difference. Pneumonia, no difference. Respiratory failure, no difference. ARDS, the only thing, we saw a few more ARDS cases in the cross multimodal arm than in the chemotherapy arm, not significantly different. So really, there was no sense of any major differences between the two, notwithstanding the fact that RT was strictly quality assured in this trial, but an important finding. And the other element of that was that the severity of complications, as per the Claviant Indo, was no different. So 3B, which is something invasive in terms of managing a complication. 4A, which is single organ failure. 4B is multi-organ failure. All that together was about 10-11% in both. So exactly the same. So this is the most important slide I have to show you. This was based on the second interim analysis. I think it was 143 deaths at this time. Good length of follow-up, as you can see, for the vast majority of patients, if you look at the numbers of risk at the bottom. But essentially, it's exactly the same, just exactly the same. And the 3-year survival for Arm A, chemotherapy, was 57%. For Arm B, cross was 56%. And the confidence intervals are fairly tight, as you can see there in brackets. And the hazard ratio at this time was 1.02 with 95% confidence intervals of 0.74 to 1.42. So at that time, with 143 deaths, the end of December, exactly what I presented to you, we could say conclusively, as we did, that there was no evidence that arm A is unacceptably inferior to arm B, because strictly speaking, that was what the analysis was supposed to analyze. So at that time, it was decided, and obviously on the advice of the DSMB, that we discontinue recruitment. So in December 2020, and the final assessment of the trial data will be in July 2022. So the first interim analysis exactly matched the second interim analysis, and it's highly improbable that there will be any change with further follow-up for this type of cancer, which typically, when it relapses within the first 2 years. So in summary, perioperative chemotherapy was not inferior to cross-regimen multimodal therapy, with good 3-year survivals in both, and pretty well equal. Notwithstanding, the markers that we do look at and we're interested in, and we expect radiation to do better with, like PCR and major pathological response rates and R0 rates and local regional nodal downstaging, were significantly better in the multimodal cross-arm. I think importantly, again, no significant difference in severity of complications or specific index complications in both. So in conclusion, there is no winner in this trial. We'll continue assessment, but it's highly it's improbable that this will change and that arm A will become different to arm B. Importantly, I think all we can say is that the data supports a clinical equipoise in decision-making if you're looking for overall survival for your patient. We have a lot more to learn from the trial, including patterns of recurrence and disease-free survival. And obviously we will understand better, but we anticipate that the local regional benefits may be counterbalanced by systemic benefits in terms of the trade-off. And that's maybe similar, maybe why you have similar overall survival outcomes at this time. Okay, hope that's in time, everybody. Thank you very much.
Great, thank you so much for that really interesting overview of the trial, and congratulations to all the centres involved in recruiting patients. It was really heartening as a esophageal cancer surgeon to see the complication rates and the mortality rates in the trial reported. You know, it's a great improvement from historical data. So demonstrating anyway that, you know, what we're delivering for our patients is certainly greatly improved from historical data. So I might kick off with the first question, and then Shiraz might be able to pick up with some of the questions in the chat box. But I suppose my first question was, were you surprised by the results of the trial?
No, I wasn't. As a surgeon who has been doing this for 30 years and seeing how standards have evolved and people have become very, very specialized in surgery in particular, but also in radiation oncology, and others, people becoming extremely focused and specialized on the quality of everything that you do for these patients. We've seen advances without being sure, because it's not all down to trials or new therapies. It's just about how we do things that little bit better. And then from a surgeon's perspective, the operation is done that little bit better and more consistently. And whether you do it open or minimally invasive, that kind of en bloc radical posterior mediastinal exenteration, if you like, that many of us try to aim for as a standard, is probably mitigating a little bit, or blurring a little bit at the benefits that might have been observed with radiation therapy in previous trials. So you might say that one of the bylines, if you like, of this trial is that it does question whether there really is a need for radiation therapy for this type of disease. Remember, we're not including T4 disease, in where there's a good likelihood that good en bloc radical surgery thoracic surgery is being performed. So I'm not surprised, but it's nice to be able to I think pretty conclusively show that is the case, and also that for those who love giving the cross regimen, which has many advantages, of course, in terms of in terms of no adjuvant therapies and so on. There's no added risk of the radiation as well, because that has been a concern for me and for over the years as well, that it might be certainly for some patients.
Thank you. So I might ask Raz to ask some of the questions that have been in the chat box, please.
Yeah, perfect. So many thanks, Prof, for that. It was really fantastic, actually, really interesting to see you. We just got a couple of questions from Fahim Habib and Mark Taylor, which really allude to, I think, the same point, which is really obviously one of the most interesting aspects of the trial is the pathological benefits, which were really seen in the chemoradiotherapy, which failed to translate into, or may I probably as a poor proxy for any benefit in overall survival, the trial, and I guess why, or any thoughts as to why?
Yeah, I do, because I think because we're removing it, you know, I think the same applies for rectal cancer. You're removing it, so you can get very excited about what's happening there. But if you're going to leave it and you're going to watch and wait, obviously that's another discussion, but you're removing it. So you just have, when it's removed really comprehensively, it doesn't really matter what's happening local regionally. Well, it does, because it might mirror what's happening. But if you were just getting, the FLOT is interesting and you're seeing a marked local effect in terms of pathological response rate, then I get excited about that, because that might bring systemic parallel response as well. So I think, do you know what I mean? I think that's, so it shouldn't necessarily be a huge surprise that a good local regional effect doesn't necessarily a translation to.
Yeah, absolutely. And just a 1 second question, I think, from Helen Coleman in Belfast. She's just asked, were there any differences in patient-reported outcomes or quality of life between the two arms? I don't know.
Helen, that's a fantastic question. We haven't got to it, but you know, I think you know, I don't want to go on too much in this, but I do think that if you were to strictly interpret this, you're going to find that for some networks, just tuning with chemotherapy, which is given maybe in a regional, you know, and spoke sort of thing, and the operation in the major center just works very, very nicely for them, and this can enable it, if you like. For some, you know, it's so much better just to have everything multimodal, but I think that option persists here. So in terms of ease of therapy, depending on what country you're in, what region you're in, and so on, and what your existing practices are, there's a lot to chew on with this trial anyway. But in terms of quality of life, been looked at, I'd be very surprised if there are major differences in the treatment-specific quality of life once the patient has recovered from the full treatment. Who always uses the adjuvant chemotherapy, which does have impact on the quality of life during that post-operative period where it can be tolerated. But no, we haven't looked at it yet, Helen, but it's one of the, it'll get with the final application.
I suppose just a quick question from Lizzie, because we're going to lead into her talk probably, but would you rather, I mean, it's a good question actually, would you rather operate including a potential minimally invasive approach after having a patient having FLOT or chemoradiotherapy, or sort of do you mind?
I think in the modern world with those doses of radiation that are given and with good RT, and my experience is it makes absolutely no difference. There's no difference whatsoever from this surgeon's perspective.
Okay, maybe we go to Lizzie next, I guess. And then...
Yeah, great, thank you. So welcome, Lizzie Smith. You're going to give us an overview of other trials that have been recently published in this world as well, and I look forward to hearing it.
Thank you. Thanks all. So you'll get my somewhat biased perspective, I think, probably now. So, you know, can you see? Let's see. There we go. Can you see those now? Is it in presenter view? Great.
Yes.
So thanks for anyone who's joined late. My name is Lizzie Smith. I'm a medical oncologist based in Cambridge in the UK. And I'm going to touch on some recent practice-changing results in peri-op treatment of esophageal adeno. I'll touch on some gastric cancer as well. And I changed it from trials to results because I'm going to talk about some biomarker work and challenge you a bit in terms of some ctDNA work at the end of the therapeutics. So hopefully I won't talk for too long. These are my disclosures. Okay, so I was lucky enough to co-author the ESMO gastric cancer guidelines in 2016, and I'm sure, as you are all aware, that we have a couple of different treatment approaches globally. Generally speaking, in Europe and the US, we use a perioperative treatment approach, so chemo before and after surgery. And as John has alluded to there, patients don't tolerate the adjuvant component of chemotherapy very well, so we might need to do something about that in future. And of course, in Asia, patients are treated more frequently with upfront surgery followed by adjuvant chemo. For esophageal cancer, this is really what John has based the important Neo-AEGIS trial on, which was the fact that we have two evidence-based treatment approaches for patients with adenocarcinoma of the esophagus and GE junction, I'd argue probably Severity type 1 and 2. And that is either a perioperative chemotherapy approach, the same as we do for gastric cancer, or neoadjuvant chemoradiotherapy. And I think there are proponents of both within the community. We all have our biases, but as I'll show you, each had significant evidence to support them. So I'll have to add Neo-AEGIS to this arrow that I made a little while ago, and it's really about the evolution in terms of chemotherapy and radiotherapy for patients with gastric and gastroesophageal and esophageal adenocarcinoma, which is operable. So starting right back in 2002, there were UK trials like OEO2, which showed the benefit of a neoadjuvant chemotherapy approach. And then we had really the first definitive perioperative trial, which established ECX, which was used in Neo-AEGIS as the chemotherapy backbone in 2006. We had the adjuvant Asian studies establishing S1 and CAPOX as adjuvant treatments for Asian patients with resected gastric cancer. And we had the CROSS trial, which established chemoradiotherapy, neoadjuvant chemoradiotherapy followed by surgery as one standard of care for patients with resectable gastroesophageal junction cancer. Then in 2017, we had a change, a new kid on the scene, and that was FLOT. And that's really replacing an anthracycline with a taxane in terms of the chemotherapy approach, and that was superior to ECX chemotherapy. And as John alluded to, during the course of the Neo-AEGIS trial, they needed to update the protocol because FLOT became the new standard of care. And so unfortunately, this is the best we've got in terms of perioperative chemotherapy, and these were the results from FLOT. And FLOT was superior to ECX both in terms of progression-free and overall survival. But if you look at the figures, the median progression-free survival for FLOT is 30 months. The median overall survival is 50 months. We only cure half of patients with this approach. So we need to do better, and we need to understand which patients are chemosensitive, which are not, and we need to identify the patients who are at high risk of recurrence and understand how we can intensify their treatment, probably not by adding more chemotherapy, but maybe being a little bit smarter about the drugs that we use. And as this is the same slide, in fact, that John showed as well. So this is the CROSS study, the neoadjuvant chemoradiotherapy approach. And we need to do better than this too, because, clearly the greater benefit with chemoradiotherapy is for squamous cancers. They're very radiosensitive. But there is a benefit, somewhat marginal, some would argue, for adenocarcinoma patients. And there is slight concern, I think, that we can certainly talk about afterwards, about the exclusion criteria for CROSS, which were equivalent to the exclusion criteria for Neo-AEGIS. So that's the patients had relatively small tumors, bulky tumors were not allowed, T4 tumors were not allowed, older patients were not allowed. We know most patients are older, so there were no patients over the age of 75. But this is, the other treatment, so chemoradiotherapy. And so this is pertinent to the new trials that we've had developed. Now, to see where we've come to in the neoadjuvant space, we need to think about what has happened in patients with advanced disease. And there's been a real revolution in the treatment of patients with advanced gastroesophageal cancer, be it adeno or be it squam, over the past year. So at the beginning of last year, there were we were using the same first-line chemotherapy for these patients that we'd been using for 20 years. So we were using a platinum and fluoropyrimidine your 5-FU, capecitabine, and cisplatin or oxaliplatin, leaning more to oxaliplatin now because it's much less toxic. And we saw the beginnings of sensitivity to immunotherapy emerging in the second-line setting, so particularly for squamous cancers, and the third-line setting for adeno. But really, the response rates to those as monotherapy is not very high. It's about 10 to 15% in unselected populations. So hadn't really made great waves until that point. But what we saw after ESMO 2020, and all of these papers have been published now, and also at ASCO just gone by when John presented Neo-AEGIS, is the addition of immunotherapy to chemotherapy in the first-line metastatic setting really improved overall survival. So breaking through the 1-year barrier for these patients, and that probably doesn't sound very impressive to surgeons who are used to curing patients with surgery, but most of these patients live for less than a year. So breaking, an additional 3 months of breaking through the 1-year barrier was important. What we did find, and what these trials have showed, and I think we need to reflect on this when we talk about the Checkmate 577 data that I'm going to discuss, is that really the patients who benefit are the patients who express a protein called PD-L1 at high levels. And that's probably about half of patients, between 30 and 50% of patients. So we count that using a CPS score and on cancer cells and on immune cells. And so the patients who have PD-L1 staining at a CPS score of 5 or greater are those who get the true benefit from immunotherapy. And I think that's important to remember. So knowing that immunotherapy is now being established in metastatic disease, the question was, how do we bring it to patients who have operable disease? And so the Checkmate 577 study is for patients who had really took the cross approach. So gastroesophageal adenocarcinoma of the esophagus and of the GE junction. It was also in non-squamous cancer patients, but we're focusing on adenocarcinoma tonight. So those patients who had cross or other type of chemoradiotherapy, they had surgery, they had residual disease. So this was already a poor performance group of patients. And what those patients were randomized to either placebo after their surgery, if they had residual disease in the resection specimen, they were randomized to either placebo or nivolumab. So nivolumab is an anti-PD-1 antibody for a year. And what this showed, I think I've just actually lost my survival curve from my slide for some reason, but it improved disease-free survival by a factor of 2. So the patients who were treated with placebo, their disease-free survival was 11 months. So that's exceptionally poor. And that just shows how badly patients with residual disease do after chemoradiotherapy. However, there's some, that was calculated from the randomization rather than surgery. So you might want to add 3 or 4, maybe two, a couple of months to that compared to other studies. But what nivolumab did was it increased survival, it doubled it. So it improved disease-free survival by a factor of 2 to about 22 months on average. So this is a groundbreaking trial. It was published in New England Journal of Medicine, and it will become a standard of care for patients with who've undergone trimodality therapy and surgery. But the question, oh, I haven't got my curve actually, there you go. The question that we need to ask is, does it benefit all patients? And I think that there are important aspects that you can consider here in the forest plot. So if you look, so the first question is, does it benefit adenocarcinoma and squamous cancer? So, and I wish we didn't do trials with both histologies, but obviously the quantum of benefit is greater for squamous cancers. So it increased from 11 months to 30 months. And we know that squamous cancers are more sensitive to immunotherapy, so that makes sense. But it did also improve survival for patients with adenocarcinoma. So there was the hazard ratio was 0.75, it's a 25% improvement on what went before. So yes, I mean, it certainly got over the line. But I think there's 2 aspects that are really interesting to me. Now, these don't affect the label. So the approval with EMA is for all patients. But if you look at the PD-L1 CPS score, you can see that, you know, this is a post hoc analysis, which is why it doesn't affect the label. But for patients who don't have a high score, the benefit is much less. So the hazard ratio was 0.89. For patients who do have a high score, the benefit is great. They increase their survival from 10 months to 30 months. So, you know, it's probably not helping the patients who are not sensitive to immunotherapy. I think what's also interesting is it really benefits the patients who have the least residual disease. So if you look at the patients who were YPT T0, they have a massive improvement in overall survival. And those who are T1, T2 have a moderate improvement. But those who had T3 or T4 residual disease, they didn't really have such an increment in overall survival. So I think this is most adenocarcinoma patients. But this will be available as a treatment choice. Certainly there was an EMA approval within the past couple of weeks for that. So this is the big question that I get asked all the time. And, you know, I'd be very willing to listen to your opinions on this and certainly your MDT opinions. I'm having a debate later in the week online. And so the question is, you know, should we switch from FLOT to CROSS because we've got nivolumab now? And so my take on this, and this is my personal take, is that adjuvant Nevo is a good treatment for who have a poor response to neoadjuvant CROSS, but the outcomes for this group are still really poor, with a disease-free survival of 19 months and no overall survival data yet. And, you know, we don't know what these results would be for CROSS. We don't know what the outcome is for patients with residual disease, for FLOT. But the PFS in FLOT is 30 months. And, you know, most patients in FLOT did have residual disease because there was a low rate of path CR. So those are my arguments towards not changing, you know, wholesale towards a CROSS approach. So my take home would be, if a patient's suitable for CROSS, high tumor, N0, that's what I favor, CROSS. But don't change to CROSS for all patients to bet on a bad response to allow nivolumab use after surgery. And I think if you think a patient is suitable for FLOT, high risk of systemic relapse, node positive, then choose FLOT. Soon we'll have preliminary data from other trials that combine, you know, immunotherapy with FLOT, and not to mention Oesophageal and Top Gear, which might also change practice. So we're certainly not changing based on this trial. I think patients who you were going to treat with CROSS, you would continue to treat with CROSS. So a few comments just on other aspects that I think we could think about in terms of changing our practice in esophageal adenocarcinoma. So, and it's really all around risk stratification. So we know now it's a big challenge that, you know, if we use FLOT, patients who have a bad response, we talk about them in the MDT, what do we do next? So, you know, is the TRG important? And, you know, we looked at this in MAGIC before, and, you know, clearly TRG is an important driver of survival because patients who have a good pathological tumor response have a better survival. But actually, node positivity is more important than TRG. So if you've got residual lymph nodes in the resection specimen, even if you've got a good TRG in the primary, you're still more likely to recur. So should we be risk stratifying adjuvant treatment based on lymph node status? And I work with the EORTC, and Florian and Lordic and I are running this trial in which patients who are treated with FLOT and have, you know, a bad response, so either node positive or indeed or one resections, are randomized to either the same chemotherapy as before surgery or immunotherapy. So very much like a Checkmate 577, but with chemotherapy. So that trial is called Vestige. It's recruiting at about 28 centres all over Europe, and it's about halfway recruited. So we'll see the results of that, I imagine, in the next couple of years. And I think based on Checkmate 8577, that's increasingly important. There's two other aspects to mention. The first is MSI. Now, microsatellite instability is not common in esophageal and junctional tumours, maybe about 3% of the junction, much more common in the distal stomach. But there's emerging evidence to suggest that patients with MSI tumours don't benefit from perioperative chemotherapy or adjuvant chemotherapy. The question is, certainly that was proven with ECX, it was proven in the classic data set, but it's not been shown with FLOT. And I think we need to see data with FLOT. Certainly we are testing MSI in all our patients and having discussions about perioperative and adjuvant chemotherapy for them. So that's certainly a biomarker to watch as well. And the last is ctDNA. So ctDNA is, as you know, and this is established in colon cancer, so fragments of the tumor that you can measure with a blood test in plasma. And what we've done And so if the ctDNA is present in the blood, it's been well established in colon cancer and lung cancer after surgery. It's a really early marker for disease recurrent because it measures micrometastatic disease that can't be seen on imaging. And so what we did in the UK, so this is the Occam's translational group that's run out of Cambridge. They collected blood on about 100 patients with operable gastroesophageal cancer that underwent perioperative chemo after surgery. And they tested, first of all, did an off-the-shelf ctDNA panel. So that just looks at about 70 genes, mutations that are commonly found in a lot of tumors. And they corrected it for false positives. And this was just published in Annals of Oncology by our PhD student. And what you can see, so this is the survival in terms of overall survival for patients who are ctDNA positive after surgery, no radiological disease. You can see that their survival is really poor. And patients who are ctDNA negative, their survival is much better, but they don't all survive. And so this is a problem with off-the-shelf ctDNA assays because they're not personalized to that person's tumor. So it could not detect mutations that they have. So this was a beginning, but we realized that we need something more sensitive. And so this is just under revision at the moment. This is using a personalized ctDNA assay. So what we do, so this is a company called Natera. There are many of the similar companies. And what they do is they take the patient's biopsy or resection specimen and they find the most common mutations and they make a specific personalized ctDNA assay for that patient. It's very, very sensitive. It's much more sensitive than the off-the-shelf assays. And so if you can find minute quantities of ctDNA in those patients. And so this is our preliminary results. And you can see that the patients who are ctDNA positive, they had very poor survival. It's a small cohort. The patients who are ctDNA negative, only one relapsed. And that was at 4 years. So this is detecting minimal residual disease. And I think what we need to do with this is kind of randomize patients to, you know, either do these patients who are ctDNA negative because their survival is so good, do they need post-operative chemo? Probably not. So we're designing a trial in the UK. Hopefully we'll be able to look at that. ctDNA positive, they actually have stage 4 disease, even after surgery. So we need to think about what treatment we can give them that's not FLOT, maybe a different treatment, targeted therapy, immunotherapy, that might help them to not develop recurrence, you know, get rid of that micrometastatic disease. So this is how I'm currently writing the new ESMO guidelines, and this is not actually what they will say, but you know, these are the things that we might be thinking about in future. So for the gastric cancers, we might be checking MSI, we might be checking ctDNA after surgery before adjuvant chemotherapy. For the esophageal cancers, we can still check MSI, I think, even though it's rare. We'll again be looking at ctDNA after resection. And then for the patients who are treated with neoadjuvant chemoradiotherapy, we will be treating them with nivolumab. And whether we should limit that to patients who are ctDNA positive or not, I don't know. So that's my summary, probably went a bit over. So we know now that adjuvant nivolumab is established as a standard of care for patients with residual disease following trimodality therapy. We've got trials looking at that chemotherapy and immunotherapy with perioperative FLOT. And I think in future, what we need to be doing is risk stratifying. So we'll be using TRG, nodal positivity, MSI, and ctDNA to either de-escalate or intensify treatments after surgery. And I'll leave it there. Thank you very much.
Wonderful. Thank you for that wonderful overview. Really interesting data. The first kind of question that sprung to mind for me was just, I suppose, what do you do with the patients who are ctDNA positive? What's your kind of standard of treatment if they've had neoadjuvant, you know, treatment, surgery, and then are ctDNA positive? What's your next strategy for them?
So I think that's a really interesting question. So, I mean, at the moment, whether they're positive or negative, they're going to receive the same treatment. But realistically, those patients are probably resistant to FLOT. So what I would like to see is a trial in which those patients are randomized to FLOT or a different treatment. So, and I think once you've got the, you know, they're probably going to be resistant to other chemotherapies. You could think about a different chemotherapy, but I'd be skeptical that it would work, to be honest. So I think that we should be dividing them into molecular subsets, like the HER2 positive patients, the MSI patients. We've got other biomarkers, you know, for other targets like FGFR and kind of zolbetuximab for the kind of diffuse gastric cancers, and getting those targeted treatments in before they relapse. And I think, though, that you probably need quite large collaborative because the biomarker selected groups are small. So it's going to take a lot of work, but I think there's an opportunity to cure more patients if we know that they have that micrometastatic disease.
Yeah, totally agree. And that's going to be the real difference, is doing something complicated with adequate numbers with such small subgroups, because it's such a heterogeneous tumor. I don't know if there were any more questions in the chat for Dr. Smith.
Just compliments, really, Lizzie.
Yeah. Everybody was overwhelmed.
Really nice.
Great. Well, I might then call up some of the cases that I had questions about. I just hopefully Brajesh is still there, because my electricity went in the middle of your talk, so I'm now no longer the host of the meeting because I had to log back in. So hopefully he can make me host, and I'll be able to share my screen. I'm host now. Great, thank you. Great. So just for the panelists, then, I was just hoping to kind of just briefly talk through some very common types of cases that we get in our multidisciplinary team meetings, and then just to give your personal viewpoints on what you would suggest to the patient or factors that you would consider when you're having that discussion at the multidisciplinary team meeting, and when you're meeting with the patient afterwards. So the first case was just somebody who I'd summarized as maybe fit for anything and has no nodal disease. So it's a 58-year-old man who presented with progressive dysphagia. He has very little weight loss, and he has no real significant past medical history. His tumor is from 36 to 38 centimeters. It's an adenocarcinoma, and it's relatively easily passable with the scope. And on his PET-CT, he has an avid primary tumor, no obvious nodes noted on it, and no metastatic disease visible. And he has an EUS that shows a T3 tumor with no obvious nodes. So what would be your approach? I might start with you, John. What would you recommend for this patient?
I've completed another clinical post having done that trial now, and for some patients it will suit them very well, and their oncologists to give FLOT and elsewhere, and then surgery in the main center. And for others, we will use cross. But it's a different discussion now. A few weeks ago was eligibility for trial. Now it's discussing both options and having been completely equal on both, but pointing out the issues, logistics of both. So no preference in this. If it was T4, cross for sure, or predicted T4 or T4A. But for this, straightforward, no bias.
And what would you find in your experience with patients, where you take this approach? What do they tend to kind of favor? What sounds most preferable to them?
Most would prefer to have their chemotherapy in a local hospital close to home. We're kind of a national center, small country, but still 3-4 hour drives for some to our hospital, as you know. So many prefer local treatment, and we're totally comfortable with that, as long as there's a pretty good oncology setup that we work with. That's in the network.
Mm-hmm. Thanks. What about you, Lizzie?
For me, I think, so I agree with John that if any tumor is suitable for neoadjuvant chemoradiotherapy, that it is this tumor. So it is a short tumor. Excuse me, it's node negative. In Cambridge, my surgeons, so the surgeons at our MDT have developed a preference for FLOT over the past couple of years. So I suspect that this patient will be treated with FLOT, and we consider the risk of systemic relapse because the patient is quite young, and I think will tolerate FLOT well. If he was in Cambridge, I will Matterhorn trial. So that's a trial which is looking at FLOT plus or minus an anti-PD-L1 antibody. And so I think that's an important question. I like to give patients an opportunity to participate in research where they can.
Yeah, it sounds like a great option for them. What about you, Shiraz?
Yeah, so I think in both, well, at Imperial, where I've worked for many years, actually, we would probably adopt a FLOT approach. And obviously, it's still at one, so we traditionally do an IV esophagectomy with a radical lymphadenectomy. But yeah, most definitely would be a FLOT-based approach. But I think in light of Neo-AEGIS, Professor Ramon's probably right. Both options should be presented to the patient and then take it from there. But I think unless the margin is threatened or we're worried about a positive margin, I don't think in most of the centers I've worked at for an adenocarcinoma, we would consider necessarily chemoradiotherapy.
Okay, thank you. So I'll just move on to the second case then. So this is somebody who's more borderline, I suppose. So it's a 78-year-old woman who has similar progressive dysphagia and has lost a fairly significant amount of weight. She's really only tolerating a very pureed consistency diet, and she's a relatively significant medical history. She's an ex-smoker of short duration. She's overweight. She does very little other than light housework around the house. Doesn't really leave the house all that much. And her tumour is a type 2 junctional tumour from 38 centimetres to the junction, and the scope doesn't pass through it. So the histology from that is that it's poorly differentiated adenocarcinoma with some occasional signet ring cells, but no mucinous component on the biopsies. And she's had a PET-CT scan that shows an avid primary, but no signs of local invasion, and no nodes and no mets, and it's at least a T3 tumour when viewed above it with an endoscopic ultrasound probe, and there were no nodes seen above, but it's not possible with the EUS probe, so incompletely staged from that point of view. So I might come to you then, Lizzie. How do you approach these kind of patients where you're not 100% sure if they're really fit for surgery? How does your multidisciplinary team assess them?
Our MDT, my oncological decision will be led by the patient's operability in terms of the surgeons. So they will see the patient, will assess lung function, get a CPET, and if they believe that the patient is operable, then we will treat the patient with a perioperative chemotherapy. I think probably most likely. If the patient is inoperable, we'll make a decision about whether the patient is suitable for definitive chemoradiotherapy or just palliative chemotherapy. So I will be led completely by what the surgeons think in this.
Okay, and in terms of, so if they think she is operable, what kind of neoadjuvant regimen would you offer?
Well, it depends on her fitness. So if she is, if her performance status is 1 and she's 78, I would consider a dose modified FLOT. So we use GCSF routinely with FLOT. We don't see many hospital admissions with febrile neutropenia. I think clearly it's important to optimize her nutrition before she starts on treatment so that she'll tolerate it better. But if I'm very concerned and want to give a patient perioperative chemotherapy, we might just consider oxaliplatin and 5-FU with no taxane. If she didn't have bad lungs, the radiation oncologist might want to give her cross. So sometimes we do actually give that to frailer patients. So, I'm conscious of my biases here as well.
Mm-hmm. Yeah, it's a very nuanced approach for a hypothetical situation as well. So thank you for those thoughts. Sure, as Lizzie mentioned, CPET. So what do you find your experience for that in terms of helping make your decision as a surgeon on whether patients are operable or inoperable?
Yeah, so in now in Oxford, actually, where I'm based now, they use CPET quite a bit actually to sort of assess the fitness of a patient. When I was at Imperial, we didn't really, in all honesty, very much at all. Didn't rely on it at all. I think Lizzie's point is really true. One of the things that I think shouldn't be forgotten is obviously Elaine has alluded to it in the chat, is the value of staging laparoscopy. Sometimes in these kind of junctional cancers, big junctional cancers, where you can't get a view of it from below, is whether or not to do a laparoscopy. I think that's also in a way a test. If they do well, if they're okay with the laparoscopy, it might be okay. If they're not so well at tolerating the pneumo with the laparoscopy, it also points to a patient who may struggle with a big operation.
Mm-hmm. And then John, any thoughts to add to the discussion on this?
Yeah, I'm just reading literally what you mean. You've proxy markers of bad disease here. You've significant weight loss, 2 stone weight loss. You've a poorly differentiated tumor. You've possible signet ring. cancer, you have an impassable tumor. So you're certainly not going to go straight to surgery with any hope of curing this patient. So you have to consider neoadjuvant. Chemoradiation, paradoxically, is even much safer in the junction because the organs are not really at risk that we are concerned about. But by and large, we would tend to treat with preoperative chemotherapy, FLOT regimen or modified FLOT regimen, Folfox or something along those lines, if depending on factors that Lizzie has already mentioned. Rehabilitation, fitness, definitely a big thing. And at the time of laparoscopy in somebody that you think is fit enough based on your usual assessment, CPET has some help, but I don't think it's necessary personally. Putting in a feeding tube at that time in somebody who's got obstructed junctional cancer that you want to treat with curative attention has lost probably 10% of their body weight or more, then would be good practice as well, I think. Sorry.
Mm-hmm. Great, thanks. I might move on then to case 3, who's a 64-year-old man who presents with dyspepsia and, again, relatively significant weight loss of about 1.5 stones. He has very minimal dysphagia, a little bit, and his past medical history is significant for hypertension and hypercholesterolemia, but he does play golf regularly, and he's the typical patient with an adenocarcinoma. He's a bit overweight with some central adiposity. So he's an ulcerated type 3 tumour with the main bulk lying along the cardia and extending up to the junction, and it was slightly tight when the scope was passing through it. And histology, he has a poorly differentiated adenocarcinoma. On his PET-CT scan, he has an avid primary, and he has probable peritumoral nodes seen on the CT component, and the gastrohepatic ligament nodes are avid, but no metastatic disease. So, and then he has an EUS that shows at least 3 peritumoral rounded nodes and 2 nodes near the origin of the left gastric artery. So I'm guessing, I think from all the previous discussions, that this would be somebody who nobody would on the panel would favor a chemoradiation approach. It would be systemic therapy. And I suppose the question for the panelists for this case is, what do you think would be the next trial that would best answer questions about what the best approach is for this patient? So that's a difficult question to answer, but any thoughts?
I don't know about the trial, but what I'd love to see in the future is total neoadjuvant therapy and no adjuvant chemotherapy unless there's very, very clear evidence of tolerability and strong, really compelling basis to do it. I think all the clinical trials, including MAGIC, including our own, including FLOT, show how difficult it is to get. So I hope adjuvant immunotherapy becomes more the standard, and we shift all the chemotherapy up front if we can. And the NeoFLOT trial of 6 cycles prior to surgery, very small study, showed that it could be done and it could be tolerated, and possibly that's where we're heading with the chemotherapy approach, in my view anyway. I don't know what Lizzie and others.
I think that's a really interesting point, John. And if you think about, I don't know about Ireland, but certainly in the UK during COVID, because we had no access to ICU beds, there was no surgery for upper GI cancers. And so we used a lot of FLOT 6 and FLOT 8 to carry patients through until the COVID peak had passed and there was access to theatres again. And so if you think about it, this is what they do in rectal cancer now, so they do a TNT approach. But I would caution that we see a lot of neuropathy. FLOT has 2 nasty chemotherapy drugs that causes damage to nerves, and going for 6 or 8 we saw certainly more PATCORs, but also a lot of nerve damage that's difficult for the patients to tolerate. I'm really looking forward to seeing the results of Top Gear. I think it has the potential to be practice changing, and so doing as much as we can up front does seem sensible. And then certainly ctDNA negative patients, hopefully after surgery, don't need anything, so we can focus any adjuvant treatment on patients that are high risk.
Great. Shiraz, any thoughts on that?
Yeah, I mean, obviously you talked about the oncological aspects, and Stephen Hornby, I think, has written NeoFLOT all over this slide. Yeah, but I think one of the things, I mean, from a surgical point of view, I guess, is also to be aware of is what operation you do. I mean, obviously, it's not really that applicable, but the cardio trial is obviously ongoing, looking at many of these kind of bulky junctional cancers and whether or not we would do either Lewis or a total gastrectomy. But I think obviously, I mean, in my experience, this kind of approach, we'd probably do an extended total with a left thoracoabdominal. Obviously, I'm in Oxford and working for Nick Maynard, so that's something we would do quite commonly. But I don't know whether Professor Reynolds or Claire, even you have any thoughts as to what kind of surgical approach you do for this?
Yeah, that's a great question. We are going to be recruiting for a cardio trial as well, but we were just discussing this week, in fact, about the potential technical difficulties in some patients of getting your extended rear limb right up into the lower mediastinum. So that'll be interesting. I don't know what you think, John.
I would, if I was comfortable doing an anastomosis in the mediastinum, well above the tumor, I would do it. But I usually default towards doing a intrathoracic anastomosis in these patients. I have to say, unless the risk factors are prohibitive. So usually in a patient who's passed the fitness criteria, I just want to get the margins absolutely right in the lymphadenectomy as best as I can. So generally not extend the total for true type 2 tumor, type 2 or type 3. Well, sorry, this is type 3 tumor. Yeah, for type 2.
Yes, that's what I was wondering.
Yeah, for type 3, yeah, no, it extended. If you can get above it, yeah, definitely, or extend a little bit into the left chest. I don't do much of that, but for type 2, definitely would be a 2-stage, vast majority.
Yeah, sure.
Which is what the cardio trial is all about.
Yeah, exactly.
Yeah. So it's different.
Yeah.
Great. Well, I think we should probably draw the meeting to a close because everybody is so generously given up their time. I have to say, I found it really, really interesting, and I'm delighted it's been recorded as well, because I'm sure I'll look back on it and take some more learning points for practice. Just before I finish up, I'm just going to briefly mention to those of you who are still with us about the TAPS course that's on this Saturday. It's designed for kind of early career researchers, and it's a free course that's going to be held over Zoom on Saturday, just talking about how to get yourself thinking about getting involved in academic surgery. So please do feel free to join us at any point. And again, that will also be recorded and made available to people who've joined our group. So thank you to everybody for your participation and for participating in the chat. The next session with the TUGS Lounge will be again on the first Thursday of next month, and Rajesh tells me that it's going to be on anti-reflux surgery. So talking about decision making for patients with reflux disease, which I'm already looking forward to. So thank you again for your attention and for your participation, and thank you to the wonderful panelists who gave so freely of their time and their expertise.
Thank you very much.
Thank you for the invitation.
Yeah,
good night.
Bye.
Bye-bye. I might log out then.
Yeah,
my electricity went right in the middle. I was like, oh no, what's happening?
I think it's a good thing you made me the host. So, I was just wondering what happened there. I was panicking a little bit, but I think you came back. So no. Brilliant session, Claire. Really nice.
I was furiously on my phone going, where's my personal hotspot?
Oh, no. But excellent talk. So thank you so much for organizing. Shala, would you like to host things on esophageal sort of, gastric cancer sort of oncology sort of things? Is that okay with you? Yeah.
Mm-hmm.
Because what I'm trying to do is obviously we'll have somebody doing the HPB side of things, somebody doing the bariatric, I'll do some bariatric, some mid and upper GI. But it'll be excellent if you lead from the cancer side of things and have it, every third, fourth meeting, we could have it on upper GI cancers. That'll be excellent.
Yeah, I'll have to get my thinking hat on about gastric cancer as well, because, most of the people that I would know would be all kind of the esophageal world. And so it'll be great for me to start thinking about who can come and tell us. So,
I think
I think we're meeting this Saturday. Is that right, Claire?
Mm-hmm. That's right, yeah.
With Kelvin and Alex Bodier, just to I think it'd be good to discuss these things. You're right, gastric cancer we completely ignore, in a lot of our things, and all of
yeah,
us.
it's only about a quarter of our practice, so
Absolutely.
it kind of falls to the wayside a little bit in terms of being, you know, right on top of things. So
absolutely, yeah. Well, so we'll see you there on Saturday, and hopefully Kelvin, he's done some fantastic talks recently, and basically covered a lot of the stuff that I'd planned to cover. And it's, to be honest, we'll see what comes out of that talk, and what he is, because a lot of the experience in upper GI cancer, it comes from Far East, and
yeah, that's true.
Fantastic, but also we need to focus a bit on our own sort of point of view on the treatment and management of these things as well. So
yeah, no, excellent. I think once you had a meeting, just let me know. I can, you know, like you did this one, Claire, you can host another session. That'll be excellent. Yeah. All right, perfect.
Okay, thanks a million.
Leave then. Thank you so much, Claire. Thank you. Cheers, Khaled. Thank you. Bye.
Bye. Bye. Bye.